We're talking about second generation, or what are sometimes called atypical antipsychotic drugs. Don't ask me why they're called atypical, other than that they function very differently from the older generation of antipsychotics. We're now probably moving into a generation of what you might call third generation antipsychotic drugs, which we'll talk about later on. So to give you a little bit of background, there was really very little progress in development of antipsychotics until the late 1980s and the early 1990s. So from 1979, when haloperidol was introduced, to 1989, there really hasn't been anything new. But since then, we've had many of these approved, including this list before you. And there are a great deal of details about each of these drugs in your textbook. We're going to talk about a few of them in some detail. One of the reasons why I selected your textbook is because it has a lot of detail on drugs that we may not talk about, but you might have questions about later on. So I urge you to hang on to that textbook if you think you're going to be involved in this field later on. So this is a whole list of antipsychotics, and we're going to take these a few at a time and then talk a little bit about some generalities from this class of drugs. So the first of these introduced in the late 1980s is clozapine, or Clozaril. This was the first atypical antipsychotic. It's clinically effective in about 1/3 of patients who did not respond to the conventional medications that we talked about previously, or the first generation antipsychotics. Importantly, this particular drug lacks the extrapyramidal side effects of traditional neuroleptics. So there are fewer side effects of this kind with clozapine. And so many people find this is much more desirable to take because of the significant extrapyramidal side effects. They still occur, but at much lower rates and oftentimes not at all. Importantly, these can even be given to movement disorder patients who develop psychosis, which will treat their psychotic symptoms but does not exacerbate their movement disorder. So we don't get the extrapyramidal symptoms, and people do get benefit get the antipsychotic benefit seen in other drugs. To give you a little bit of a background in this area, these drugs were first introduced in the late 1950s in Europe, but were pulled due to a fatal loss of white blood cells in some patients. And this is a potential problem still with this drug, but what we've discovered is it's much less common than was once thought. A large multi-center trial in the United States found 30% of patients who did not respond to traditional drugs responded well to clozapine, and with prolonged use, this may be actually 60%. So it's an incredibly effective drug, a great tool to have in the arsenal. And only about 1 to 2% of patients develop loss of white blood cells, which is reversible with cessation of treatment. So an important component of treating a patient with clozapine is making sure that they get regular blood tests to track whether or not they're having loss of white blood cells. So keep that in mind. If this is something that comes up in your future, you want to think about this as a potential issue with this particular drug. This is a potentially fatal side effect, not to be taken lightly, but it can be mitigated through regular blood work. And we're going to see with other drugs to treat other disorders that regular blood work is a critical part of treatment. So we have to understand while these drugs are used, they often require additional treatment from a physician, tracking from a physician. You can't just have someone be on these drugs and go off on their merry way. This is a whole treatment profile we have to think about. So they're effective enough that most patients can live on their own. And that's what's really great about these drugs, is most patients can go back to work or school. They work very well as long as the patients stay on them and don't find the side effects to be too problematic. So as with most drugs that we're going to talk about, we'll start by talking about the pharmacokinetics. And of course, this is how the drugs are handled by the body. The drug is well absorbed orally, reaches peak plasma concentrations in about 1 to 4 hours, which is relatively fast for an oral antipsychotic. So very effective, reaches its peak plasma concentration very quickly. There are 2 major inactive metabolites that are developed from the metabolism of this particular drug. So it does take longer to get rid of the byproducts, but the active metabolism is relatively quick for some people. One problem with this drug is that the half-life is highly variable, and it's patient by patient. It can be from anywhere to 9 to 30 hours. So dosing is going to really depend on the patient, and again, it's going to require careful tracking. So the dosage varies typically from around 200 to 400 milligrams. What's really important is that the most effective way to dose this drug is to monitor plasma levels during initial treatment to determine the effective dosage. And so you can actually test how much drug is in the blood after so much time has gone by to see what the half-life might be, to then come up with an appropriate dosage regimen. When I talked about pharmacokinetics as being an important part of understanding drugs, this is one of the reasons why it's critical for us to understand things like metabolic half-life, because they do have a direct effect on the amount of a drug given and the timing intervals at which we give a drug. So it's important to understand when you are given a prescription and it says take every 4 hours, that's not there just for no reason. It's because the goal is to reach a particular level of the drug in your bloodstream, and taking it every 4 hours is an important part of that process. And so one of the ways we have to think about with clozapine is getting the right dosage for that patient, and since this is such a highly variable drug, it requires some additional work. So let's look at the pharmacodynamics. The drug antagonizes our D2 receptors much less than it does our D1 receptors. Again, these are dopamine receptors that are involved in various pathways in the brain. This is a significant 5-HT2 receptor antagonist, so it's involved in serotonin as well. It's also an antagonist to 5-HT1A, a different serotonergic receptor, histamine, muscarinic, and adrenergic receptors. So much like the other older antipsychotics, it's involved in histamine, acetylcholine, which is the muscarinic receptors, and of course the norepinephrine, which are the adrenergic receptors. There is a little bit of other dopamine receptor antagonism as well, the D3 and D4 receptors, which we will talk about later on in the semester, being involved in some other drugs. So very broad effects in the brain, makes it very effective for as an antipsychotic, but also has some pretty significant side effects, which we'll talk about next. Efficacy of this particular drug is well documented. Its use is limited by side effects and its potential toxicity, particularly the white blood cell problem. These common side effects include sedation. About 40% of patients experience significant sedative effects, might be dose limiting. That is, we might have to keep the drug at a lower dose to keep from sedating patients too much. And it also influences compliance because people just don't want to be sleepy all the time. And so people won't stay on the drug because they're not able to function because they're just too tired. Another significant problem with most of these second-generation antipsychotics that we're going to talk about is significant weight gain. And with clozapine, this is about 80% of patients that experience significant weight gain. And we're talking about 20 to 40% weight gain. So this is a 20 to 40 pound weight gain. And so this isn't just a few pounds here and there. This is significant weight gain. And we'll talk more about that here in a bit. There is a significant risk of seizure from clozapine. There seems to be an effect on seizure stopping receptors, and so there is an increased risk for seizure, particularly anyone who is prone to seizures. Risk of increased saliva production, which sounds unpleasant. And again, the agranulocytosis, which is that loss of white blood cells, and this is potentially fatal. The white blood cells are an important part of your immune system, and significant loss of those can result in significant health issues. So that's an introduction to clozapine. Very great drug, still used quite a bit, very effective. In fact, we're going to compare its efficacy to others as we move along because it's kind of our hallmark of efficacy. So risperidone, or Risperdal, is our next atypical antipsychotic. Again, it's the second atypical antipsychotic introduced back in 1994. So these drugs haven't been around very long. They're less than 20 years old. And so these are relatively new. And so trying to understand their effects is important in terms of understanding the causes of diseases like schizophrenia. Excuse me. This is a potent antagonist of our D2 receptors and the 5-HT2 receptors, which results in improved control of psychotic symptoms because it only affects those two receptors, so there is less sedation than there is in clozapine. There are minimal extrapyramidal symptoms at low doses, so provided that you're able to dose at a relatively low amount, you don't get the extrapyramidal symptoms. They do, however, emerge at higher doses. So this is a good drug, relatively similar to clozapine in terms of side effects, potentially more extrapyramidal symptoms than clozapine, but also does not have some of the other side effects that clozapine has. So let's look at the pharmacokinetics. It's well absorbed orally and highly bound to plasma proteins, so that makes it distributed effectively. Importantly, it's metabolized into an active intermediate metabolite. So while the initial drug may have a half-life, then the intermediate metabolite will have its half-life as well. So it extends the efficacy of this drug, which again has important implications for dosing regimens. There is a long-acting injectable form available using a fairly novel procedure in which the drug is placed in a highly biodegradable polymer in little microspheres, suspended in water. It's injected into the muscle, then those polymers break down over the ensuing 2 weeks and slowly release the drug into the bloodstream until you get a relatively stable amount of drug that lasts up to 2 weeks. So for patients who have difficulty complying with a medication regimen, this is a great way to dose because they can come into the clinic every 2 weeks, get their injection, you can check on how they're doing, and then they can be off on their way. So they don't have to be taking a pill every day. We're talking about a population with significant cognitive disruptions, and so trying to get them to take a pill every day is pretty difficult. So this is a really effective way to go about treating psychosis, particularly in a patient who's living out in the community. In terms of the pharmacodynamics of risperidone, has a similar efficacy to haloperidol in reducing positive symptomology at doses with low incidence of extrapyramidal symptoms. It's not as effective as clozapine, but with a better safety profile, so this makes it a good first-line agent. So while it does not have the high efficacy that clozapine has, it's much safer because we don't have the risk of dropping white blood cell counts. So this may be a good first choice if you can't use clozapine. And again, the intramuscular injection really makes this a pretty palatable choice when it comes to treating a patient. Side effects of risperidone include somnolence, agitation, anxiety, insomnia, and headaches. You get extrapyramidal symptoms at high doses, potentially in patients with no previous exposure to antipsychotics. So anyone who's new to antipsychotics are more likely to have extrapyramidal symptoms. Do get weight gain, but only about 50% of that seen with clozapine, so it's not as bad as clozapine. And importantly, this drug can be used in mothers who are nursing. So a mother who has given birth and is nursing their child, this is safe for nursing infants. Not much of it is passed on, about 4% is passed on to a nursing infant. So it is safe for that particular use. So this might be, again, an important go-to drug in those instances. There are other atypicals I want to briefly talk about. I don't feel that it's necessary to go over every one of these drugs in detail, but these are some you may have heard of. You've probably certainly seen advertisements either for these drugs or for attorneys suing people who make these drugs. People make their living a variety of ways. So olanzapine, or Zyprexa, is structurally and pharmacologically similar to clozapine. Doesn't have the toxic effects on white blood cells that clozapine does. It's as effective as haloperidol, but is much more expensive and with a much greater chance of weight gain. So everything's a balance. Obviously, cost is going to be important in this population because most of the times they're going to be Medicare, Medicaid patients because they're probably not working, they're certainly not private insurance patients, and so cost is going to be an important thing to consider. And certainly the weight gain is an important consideration. It affects compliance and certainly can affect health. Seroquel or Quetiapine, is a 5-HT2D2 blockade drug that will reduce positive symptomology in a rate comparable to haloperidol. So it's, again, efficacy is similar to haldol. This is also used to treat bipolar disorder, and unfortunately has a high potential for abuse. Apparently this drug has been used in trying to keep prison populations under control, control aggression in those populations, and apparently it has very similar effects to barbiturates and other hypnotics, and as a result has a great deal of potential for abuse. So that's naltrexone and Seroquel. Abilify, or aripiprazole, your guess is as good as mine, we'll call it Abilify, is the first of a new third generation of antipsychotics. This is a whole different kind of drug, and in fact this drug can be used in a whole bunch of ways, some of which I think are good, and I'm not sure if it's just being used too much in too many places. But let's go through the important information. This is a partial D2 antagonist. What's interesting is it seems to mimic the D2 receptor, or the effect of D2 on a receptor, but with lower potency. So rather than acting like dopamine 2 does, it essentially does, but at a much lower effect. So it reduces, because it's taking up the receptor, it reduces the efficacy of D2. So it reduces D2, but not to the great extent that a typical antipsychotic would. Also blocks some 5-HT receptors. It also produces anxiolytic and antidepressant properties, that is, it relieves anxiety and depression, and in fact is oftentimes used in conjunction with antidepressants. And it's actually approved for that as an addition to selective serotonin reuptake inhibitors for depression. In fact, you've probably seen commercials on TV saying, ask your doctor if maybe we should add Abilify to your drug regimen. So it is approved when used in conjunction with another antidepressant. And so it's possibly beneficial to some patients who aren't getting enough benefit from their SSRI. It's also approved to treat bipolar disorder and autism or spectrum disorders, particularly for conduct problems, aggression in that particular population. So it's really used in quite a few places. It has fewer side effects. Particularly important is it has no weight gain or some of the cardiac problems with these drugs, the previous drugs we've talked about, which I'm going to talk about here in a minute. So it's a good choice. Whether or not it's potent enough for all patients is another question, but it's another tool in the arsenal. Well, I want to talk about in a little bit more detail some of the prominent side effects of these second-generation antipsychotics, because they are important and they are across the entire group. As a group, these drugs tend to induce a lot of weight gain, and that's of course an issue. It may be related to some compliance issues. That is, people might stop taking them because they don't want to have all that weight gain. And it varies by drug, and I urge you to look at figure 4.4 in your text. It shows you specifically the kind of weight gain associated with each drug, and so that's an important thing to consider. One of the problems with this particular side effect is its cause is not particularly clear, and that's an important question, because certainly it's going to tell us a lot about obesity, but it's also going to tell us what we might be able to fix in these drugs chemically to try to get the antipsychotic properties without this weight gain problem. Problem with tinkering with neurotransmitters is they're really not as specific as we might want them to be. So trying to work that out is a problem. As a result, or related to the weight gain, a lot of patients in using these particular drugs develop diabetes and hyperglycemia, so they need to be treated with additional drugs, which of course is a cost and additional compliance. And then finally, there are some cardiac anomalies. So any patient on an antipsychotic probably needs to be regularly seen by a physician, and probably absolutely needs to get regular EKGs, because you can see the cardiac anomalies. And look at your textbook for more details. I won't ask you the details aside from knowing that this is one of the side effects. Well, these drugs are also used outside of treating schizophrenia and psychosis. They're used for treating bipolar disorder. All of these drugs we've talked about, except for clozapine, are approved for use in bipolar disorder. Some of them are used in treating unipolar depression, which we're going to talk about in the coming weeks, or coming days, I should say. An off-label use of this drug is for treating dementia patients. And an off-label use of a drug is one in which the drug is prescribed for use for which it's not approved, but which there might be evidence for. And this happens all the time. There are a variety of instances where a drug can be prescribed off-label. This is one of those cases where it's not approved for use in dementia, but there seems to be evidence for its use. It reduces delusions, aggression, and agitation in dementia patients. Really makes them easier to treat clinically, because obviously aggression and agitation make it difficult to treat them in clinic. Autism spectrum disorders and pervasive developmental disorder are both associated with agitation and aggression, and so some of these neuroleptics might be used to treat that aggression and agitation in those populations. It's obviously something to be considered. Usually only in the most severe cases would you need to do so. There is also some evidence for efficacy of these drugs in post-traumatic stress disorder, obsessive compulsive disorder, and in treating borderline personality disorder. And borderline personality disorder is one of those diagnoses that's incredibly difficult to treat, and there is some evidence of efficacy, but not a great deal. But they're certainly used for that. So that's going to conclude our discussion of antipsychotics. We're going to talk next about antidepressants, which are, of course, an important class of drugs. Lots of people on these drugs, and so we'll be talking about those next time. Thank you.